everyone. I hope you enjoyed lunch. Some of you will have seen this title before, and that's how far it goes. And then actually a lot has happened since I last gave this talk, so I think it will be quite an interesting story. It will answer a number of questions. I think Paul asked this morning, some of the others, about where metformin sits and what should we do when. So let's start. So this is the old and the new, and in fact, even on this already, this phone, the second phone, the iPhone, the smartphone is already old, you can see. But the discussion is new always better? Was it nice to sit on the stairs with the old phone and chat to just one person, not distracted? Or is it actually better to have everything in your hands and you can do whatever you like at the same time? So you talk to your mother on WhatsApp while you're answering your emails, ordering your food, and so on and so forth. And this goes on in life. So was it better to sit in an old coffee shop, or is it better to just grab your coffee on the run and off you go? So old and new is quite debatable whether new is always better. And in 2008, this is a world cloud. So this is the ADA and EASD, so the American Diabetes Association and the European Diabetes Association guidance in 2008. And I did word cloud, so I threw every word into this generator, and this is what we were talking about. You can see it's metformin, it's about glycemic control, insulin resistance, and not much else. And in 2019, which you probably already have seen, the new drugs started to appear. We talked about CKD, about heart failure, about cardiovascular events. So the mood has changed quite significantly to cardiovascular protection. And this was a consensus in 2019, and you don't need to dwell on it because it has changed again, but you can see that metformin is, I think I will point out, metformin is here. So you have diabetes, we talk to you about lifestyle, and very early on we come in with metformin. And I think that's what most of us do, that's sort of natural to us. And at this stage, patients say, please, can I just have lifestyle? And we try to say, actually have both if you can bear it. And then you decide on the drugs, on the additional drugs. So this was 2019. We were having a patient-centered approach. We are looking at early combination if necessary. We were using insulin early. We were saying there's no point in waiting. And we were starting to consider cardiovascular comorbidities. And at that point already, 2019, we said if you have cardiovascular disease or high risk of cardiovascular disease or established kidney disease or heart failure, use one of the newer agents, an SGLT2 inhibitor or GLP-1 receptor agonist. And we were starting to switch around last few years, saying maybe insulin is not your first step as an injectable, but you use the GLP-1 receptor agonist, which interesting patients found much more palatable to say, yes, I'm injecting this, than insulin. So insulin has quite a connotation for many of our patients. There is a thing called physician inertia, and I think it's both patient and physician inertia, in that we do something and we say we should look at it 3 months, but we actually don't do the next step. And I think that's probably just human nature, but often contributes to things not being optimally controlled. So I think that's just something to be aware of if you go away from today, is our inertia to make a next change is quite a big barrier for everyone. And so this is new. So this is from September 22. This is my word cloud again. For some reason, I couldn't get the word diabetes out of the generator, so it's right in the middle. But you can see it's really not very much about glucose at all. You see it's a lot about cardiovascular risk, kidney disease, and endpoints. And this is a guidance. And essentially, I talk you through it, but there are sort of 3 points. It's focused on managing weight loss. It focuses on person-centered care and on equity of care. It looks at both glucose and weight-centric approach at the same time. We always used to say, oh, weight loss is a bonus, but really we're after the glucose. Now it's saying both glucose control and weight loss have merits in themselves. And it focuses on kidney disease and heart disease. You've seen some of these slides from Melanie Davis this morning. So they've done all this. They had an amazing graphic designer, I think, who needed entertaining. And they put these 4 things together. So they say glycemic management, weight management, cardiovascular risk factor management, and cardiorenal protection. So these are your 4 pillars of your diabetes management, of your management of type 2 diabetes. This slide is really just to remind you that, of course, this changes if you have somebody who has a very short life expectancy, or somebody who you worry about hypoglycemia, or somebody who's actually too poor to adhere. If you're in a place where people have to pay for the diabetes medication, your options are changing. So it isn't really that you do the same for everyone. I think it takes quite a lot of thought and skill to make this work. Why do we care about glycemic control? What do we want to achieve? We want to reduce symptomatic hyperglycemia. We want to reduce complications, and you know the studies, both in type 1, the DCCT, and the UKPDS in type 2. And you want to reduce macrovascular events, and do this, obviously have some benefits immediately, but also think of the longer term. So this is a weight reduction as a target intervention. You've seen this morning. You've seen the trials to just say the more weight you lose, the better it is for you. And the weight loss seems to have benefits beyond the benefits of glycemic control. I mean, it sort of goes without saying: blood pressure, lipids, quality of life, ability to exercise, ability to hold down a job, and so on. And so this is putting your patient in the middle of all this. So I think this is sort of, some of these slides may be slightly insulting to you, because that's what you do every day. In hospital, we seem to remember to remind the specialists of going back to the patient rather than to their specific organ. And this is what the new sort of suggestions of guidance are. And if you start at about start at 1 o'clock, and you go assessing the patient, you think, what would be helpful for this patient? What would influence their choice of being able to adhere, to comply with the treatment? Use the patient's input to make this plan, otherwise you are lost. Agree on the plan, implement the plan, support your patient. So this is with all your practice staff, that can't be you on your own. Agree again, review, agree, and start again. So this is go round and round. And this is the evidence. This is just for those of you who are interested in why the guidance has slightly changed. I'm coming to the guidance now, but these are the new trials which suggest cardiovascular outcome matters, heart failure trials, and renal outcome have really been shown to be improved with the newer medications. This is the ESD and ADA new guidance, and I will take it sort of slightly apart for you, because it looks quite complicated, but it actually isn't. And if you look on the left-hand side here, I'm going to just take you to this part first. Yeah. So this is the right-hand side you've seen this morning, is achievement and maintenance of glycemic and weight management goals. So this is all about blood sugar and weight. And then this is about cardiovascular risk factors and comorbidities, this left side. So this is where we are going. And you can see that really it's telling you that you're looking at your patient and you're saying, do they have any cardiovascular risk, any risk factors, any heart failure, any kidney disease? And this determines which drug you're going to use. So if you have a patient who has current or prior symptoms of heart failure, you would use an SGLT2 inhibitor. So that's as easy as it goes. If you have known chronic kidney disease, again, you use the SGLT2 inhibitor first, or a GLP-1 receptor agonist if forever there's a reason why you can't. And this is your group of cardiovascular risk or cardiovascular disease. And again, these are your drugs you're using. If your HbA1c remains above the target you think is suitable for this patient, you use the next agent. And what you will see, so this is what we've just talked about. What you will see is that the evidence is actually, the benefits are very, very strong. So the numbers you need to treat are very low to get benefit on cardiovascular risk or kidney disease or heart failure. So this is, so in a way, you saw this in a second talk about precision medicine, but it's really the highest yield is in your patients with the highest risk, the highest immediate yield. This is I'm going to put this here because you will be able to have access to the slides, and it just reminds you of which agent is suitable for what. You don't need to study this now, but it will be there. And the question is, you will have seen this, that in this model, in this flow chart, metformin doesn't really get to make a big appearance. So metformin used to be the star of the show, comes on early, keeps popping up, and it's not happening anymore. And the reason is that actually they looked at, there's lots of studies now, or some studies rather, looking at change in HbA1c in drug-naive patients. This is in people who already have metformin. And you can see that the effect is similar, if not better, in those who are drug-naive. So there seems to be no, counterintuitively, I think, but no real benefit in the data to those patients who have been on metformin first. And again, it's the same for cardiovascular risk. So it's the same. Those on metformin on the right, those, no, this is, I apologize, this is all-cause mortality with increased cardiovascular risk and with low cardiovascular risk. So again, you can see the agents are effective without worrying about metformin. However, these are networks, and they can tell you how many studies have been done. And you can see how thick, so these are direct comparative trials. If the line is very thick, the size of the circle is how many trials were done. And there's very few trials are done just comparing a drug with metformin. So actually, when we are saying there's no data on metformin, it's because the trials haven't been done. So there's no data to support metformin as a first line because these trials haven't been done. Metformin is dirt cheap, so they are not going to be done. So it's a sort of unfair race, really. Yeah. And there's another interesting slide, which I've just come across recently. It's a really old paper, 1995, where it seems that metformin works best when used with high blood sugars. So we tend to use it in people who have a low blood glucose. They come in, we say you have prediabetes, very early diabetes, metformin would be good for you. And metformin doesn't do much. So this is change in fasting plasma glucose here. And when you look at the metformin, so diet on metformin is a dark square, dark bar. You can see the higher the glucose, the more effective metformin is. So again, I think if we haven't used it early on, perhaps we should keep thinking about it later. So it's a good drug, it's an effective drug. So the consensus recommendations are that the newer agents, so GLP-1 receptor agonists or SGLT2 inhibitors, should be used independent of the background use of metformin. So metformin is, as I say, it's sort of been, it hasn't been taken out of the guidelines, but it's been parked somewhere. And it should be independent of the background use of metformin, and again, independent of the baseline HbA1c. So if you have even a good HbA1c, whatever good means, a near normal HbA1c, if your patient has other comorbidities, heart failure, kidney disease, cardiovascular disease, or high risk of cardiovascular disease, you should use those agents. They will be beneficial. And that's both the American and the European consensus consensus guidance. Yeah, and this is just an example of how effective. So this is a meta-analysis of the trials, how effective the SGLT2 receptor agonists are for kidney composite outcomes in this patient group. Yeah. So I've shown you this again for kidney disease. There's lots of different trials. Again, you don't need to study this trial, but it shows you examples of patients with and without diabetes. All these have actually, all these have diabetes, but the first trial also included patients without diabetes, and then some had more severe kidney disease with significant albuminuria, and others didn't. But all have positive outcomes on these composite endpoints. Yeah. So this is really what I've just said. You should use one or the other of these new agents. If one that isn't tolerate or contraindicate, you swap them around. So it isn't very complicated. So this, I'm just going to summarize all this. This brings me back to again, this is the EASD, American Diabetes Association summary in graphics. So this is patient-centered care, which I think most of us all know about. So this is to remind you, this is cardiorenal protection we need to think about, cardiovascular risk factors I think we need to think about. Here's your glucose, which used to be our main worry, and then weight management. And they're all equal components of care. And then this is how to do it. This is principles of care about being fair, being equitable, being culturally sensitive, and so on. And then when you take these apart, this reminds you, this is your glycemic management. Use metformin or an agent or another agent. Use combination therapy early on to achieve your goals. And obviously watch out for hypoglycemia, especially in high-risk patients. So you don't want to, obviously, your people with severe cardiovascular disease to have hypoglycemia. I think we talked about this morning a bit. It says here, use combination therapy. I never tend to start 2 drugs at the same time, but I may be in a luxurious position. You may be in a different position that you have fewer opportunities to see your patients if you're swamped. So I tend to say, do this, and then if you're well, 2 weeks later do this, and then 2 weeks later do that, because patients will do something, have a side effect, and then you lost all your drugs you offered them in one fell swoop. So, but the guidance says you could throw it all at them. And then this is your second main stem, your weight management. So again, you've seen this morning. This is general lifestyle, nutritional advice, physical activity. Consider medication. Have them in a weight management program if you can, and then think of metabolic surgery. There's always a question whether metabolic surgery will actually just disappear as we have the drugs available. And I think at the moment, it's still going on, but my feeling would also be that this may be just for a very small, restricted group eventually. And then this is your third sort of pillar of management. This is thinking of your cardiovascular risk factors. So in a way, we call these patients, we say, oh, they have diabetes, but really what they're having, it shouldn't be called diabetes. They have a very high cardiovascular risk. And I'm seeing Professor Cunningham in the audience, so I'm not going to forget the kidney. So they have a high cardiovascular renal risk, I think, is really the worry. Yeah. So you think of the other risk factors, you look for them, you look at their blood pressure, their lipids, you think of antithrombotic agents as appropriate, and you remind them of smoking and enroll them, if you can, in a smoking cessation. And then your fourth pillar of this diabetes management is what we already talked about, is managing is offering cardiorenal protection with, as we discussed. So you look, do they have renal disease? Do they have cardiovascular disease? Do they have heart failure? And that will help with your choice of medication. Yeah, and this is the same, just putting beautifully all together. And this is what you saw at the beginning, and it looked very difficult, but in fact now it's very straightforward. So you have glucose and weight management here, you have your cardiovascular risk factors, your renal disease, your heart failure, all here, and you do a stepwise approach. It probably doesn't matter. I wouldn't lose a lot of headache over, a lot of worry over which drug you use first. Most people will end up on more than one, and it's better to do something than to worry whether you're doing the right thing, really. For this patient cohort. And again, Melanie Davis mentioned this morning, what's on the horizon. So there's newer drugs, and she talked about weight, but again, they also obviously have a great effect on diabetes management as such, so on glycemic control, the augmenting insulin release. We know they have effects on the brain, on your relationship with food. They have effects on the gut, on the stomach, with satiety, on gut transit, and directly, obviously, on glucagon and insulin. Oops, sorry. And then there's now, if you thought the dual agonists aren't good enough, there's now in animal studies of triple agonists. So we earlier saw weight loss of about 20-25% with a dual agonist. This is now the next step up, adding glucagon to this mix. So we may in a few years talk about that in people. So overall, we are looking for an empathic, person-centered decision-making. Obviously, your local resources will have a huge impact. Individual social determinants of health of your community will have a big impact. You need to look at health behaviors. And someone again earlier talked about motivational interviewing, behavioral changes. And again, I think you are all well trained in that, more likely than hospital doctors. A lot about diabetes self-management education is important because the numbers are too big for us to manage. You need to be aware of patients' cardiovascular risk, how to get them to attain good glycemic control and weight goals to prevent complications and optimize their quality of life. And I think our story should perhaps be more about optimizing quality of life, keeping people well for longer than about specific targets. And a lot is mentioned about equitability of care, but of course that's quite difficult to achieve for the individual doctor. So these are the 4 stems you saw before, and I really just wanted to remind you, so it's glycemic management is as important as weight management, as important as cardio-renal protection, and cardiovascular risk factor management. And this is just because I'm homesick. I'm going to indulge myself. This is called the Humboldt Forum, which is a sort of museum, cultural institution where people meet. And it's incorporating an old castle, as you can see, with a new architecture. And you could argue forever whether new is better than old, but somehow we got to aim to combine those two. Thank you very much.